AVN. Okay, and in second part, I was requested to take surgical ultrasound, like specifically piriforms and pudendal, just at the last moment because. Some guidance. To start with, I have no financial support, no other conflicts of this lecture. So quick learning objectives include a stepwise hip ultrasound technique, how to do an intra injection safely and accurately. And finally, at the end of the lecture, like we need to have some kind of take-home message. What is the evidence for the PRP or regenerative therapy in the context of AVN? So when we talk about the heat injections, typically we do intra-articular injections for osteoarthritis, quite a lot of time for rheumatoid arthritis, and also quite frequently for peripheral spondyloarthritis involving the hip joints with high CRP, HLA-B27 positive, patient is limping, a lot of pain there, and also the AVN. Probably these are the four indications. And various things are injected, starting from local anesthetic, corticosteroid, your regenerative stuff, PRP, BMAC, stem cells and so on. And of course, we also do the radio frequency ablation. So just a very brief anatomy. If you look at here, we find those muscles, hip joint, head and neck there, and the muscles around it, the iliopsoas, medially your adductor group of muscles, and laterally gluteus and medius and minimus getting inserted into the trochanter of the hip. Okay. So again, if you take out the muscles, what will come across the ligaments, which reinforce the capsule of the hip joint, the iliofemoral ligament, and on the top of that, the joint capsule. So when we do an ultrasound guided injection, so the target is that anterior recess of the hip joint, and the ultrasound probe is kept in this oblique plane, and that is head and neck junction looking at the anterior recess. Okay. So why to do that with ultrasound guided? So there are few studies, and they have found that if you do that with a landmark guided, the success rate is only 50 to 80%, and there is a high risk of femoral injury. On top of that, you can also have a femoral artery injury with a big hematoma there also. With ultrasound, it's kind of 97 to 100%, but if you're doing it, a season, you can do it all 100% almost all the time. So coming to the how to do this. So the stepwise approach is by position, keep in a neutral position. You can do a bit of external rotation if you want. And then the anatomical position has to be manner, okay, aligning with the head and neck of the femur there. Okay, the transducer most commonly is a curvilinear low frequency transducer, but sometimes it's a very lean and thin, you can use a linear transducer. Needle orientation has to be in plane, of course, all time. There is no out of plane approach for this technique, and needle has to go from inferolateral to cephalomedial approach or supromedial approach. So here again, just sonographic image just to show you. So this is cephalar, this is caudal, this is the acetabulum, labrum with a little bit of contrast. There's a gale there, this femoral head, and that will transition to femoral leg. And if you do a femoral sap will be there. So the top is the iliopsoas. So this is the first scanning technique. The stepwise scan in the transverse plane, as if you are scanning a femoral nerve block. So you find the femoral vein, artery, nerve there, this iliopsoas muscle, the fossa iliaca, and that side the sacrum is there. So you can find the femoral head and capsule there. And then from here, change the probe to 90 degrees, aligning in this plane, like as if you are trying to see along that head and neck junction. So when you do that, what you find, this is the femoral head, this is your articular cut, this is the labrum there. Labrum, acetabulum will be there like cephalar, and that is the anterior recess that we call about. This is the anterior capsule and the posterior capsule. They are reinforced. They kind of extend up to the junction of your IT area, intertubercular area there. And that is the target, is the head and neck, that is the target for the hip injection. You don't have to go blood inferior or even blood superior. No need for an intravenous antibiotic, but it's your choice. When you very close to the probe, you have to go a meter away from the probe. That will improve. Okay, so let us play this video. I hope this works out. Yes. So here, as you see, that is my needle tip. There I am going head and neck junction. I have started injecting. That's corticosteroid. See, spread careful like that. You can appreciate very well. You are there. You go touch the periosteum there. Just withdraw a millimeter and do the injection there. This is again another video which was done recently in a patient with peripheral spondyloarthritis. This is my echogenic needle. You can see that I'm just less pressure, try to identify with the color Doppler. Make sure be cognizant of put pressure so that any kind of post procedure hematoma, big hematoma doesn't happen there. So I use after the spinal needle like regular ones. It is deep to the iliopsoas ligament within the anterior, injected usually 4 to 6 ml of total solution, can be PRP, can be local anesthetic or steroid. So don't go too capillary, don't target in order to go to the joint. You just have to stick to the head and neck junction. Okay, so don't go capillary to avoid traumatizing the acetabular labrum there. Okay, so avoid the neurovascular structures over there. Like this, put a color scan, make sure that you identify those blood vessels. The target is here, head and neck junction there. So you have to go like 2 centimeters away from the probe like this. That path we have to follow. Coming to the use of PRP in AVN. So this is an excellent paper from Chandigarh itself, PGI Chandigarh. So from the orthopedic department. So we know that's an ARCO classification, ARCO, radiological finding, MRI finding, 1, 2, 3, and 4. So 1 early AVN, 4 definitely kind of head collapse. You have to do a surgery, in terms of either a osteotomy or a total hip replacement. So in this study, they compared core decompression with versus core decompression and PRP, and they followed them for good 4.5 to 6 years. That's pretty impressive. So what they found that PRP used following a core decompression, if you are adding PRP in your core decompression, that provides a significant pain relief, better functional recovery, and also that stalls the process of further progression of your collapse or the head necrosis. So definitely, so this is in early stage of osteonecrosis of the hip or AVN, core decompression with PRP has a better outcome when compared to core decompression alone. So this is another RCT which compared extracorporeal shockwave therapy with AVN, with PRP. So what they did, 4 sessions of extracorporeal shockwave therapy, 1 session every week, 4 sessions. Similarly, PRP, 1 session every week for 4 sessions, like 2 group, 4 sessions of consecutive 4 PRP, each week apart, and then 4 extracorporeal shockwave therapy. So what they found, that both groups they did well, they had good response in early grade 1, grade 2 and early grade 3, but intra-articular PRP appeared superior to shockwave therapy in pain relief and also in functional improvement. So this is again another systematic review on platelet-rich plasma in the treatment of osteonecrosis. So what they found, there are various mechanisms by which PRP may help in AVN of the hip, angiogenesis, osteogenesis, to accelerate bone formation and inhibit the inflammatory reaction from the necrotic tissue. So if you are doing this PRP in the early stage of osteonecrosis, then it has potential in healing and also can prevent further progression of the disease. So fluoroscopy, quick, office-based, you heard of radiation exposure when compared to fluoroscopy guided CT scan. So if you are not doing ultrasound guided hip injection, you must start doing it. It's very easy. You can do it in OPD itself in a couple of minutes time. And then from the evidence, whatever we have so far, decent amount of literature, that PRP is not bad if you are doing it in early AVN. Don't forget to do it 3 or 4 sessions in that we have more beneficial, but we cannot say on the basis based on few patients. You have to have a RCT or high number of patients to say about that. And when you do a core decompression, last moment. So gluteal ultrasound, it is all about the so go to 45 or 46, I think. So this is what I take in I conduct 1 week of MS ultrasound course, so it is so that's presentation from those lectures. Okay. Okay. So when we talk about the piriformis syndrome, if you look for the literature in the recent times, I think that has changed. The better terminology that is used these days is a deep gluteal syndrome instead of the piriformis syndrome. It can be anything, and piriformis syndrome is a subset of that deep gluteal syndrome, because where in the subgluteal space from the non-discogenic cause, your sciatic nerve can get irritated, can get impressed, leading to pain in that posterior thigh, sometimes can it also. Keep this in mind also, you have this ischio-femoral impingement syndrome also from the quadratus femoris, and you should not forget in patients who have inferior gluteal pain and more so when they are sitting for a while. So piriformis is the pain rely on the clinical rule and from the lumbar disc, if that is not there and pain is on sitting on some other day, is greater trochanter there. So this is one of the powerful extra here. You have your quadratus femoris. So these are the 5 muscles who are the lateral or the rotators of the hip joint. So sacrospinous ligament. When the sacrum aware enough, here also for the medial you have pudendal artery. So even through the Alcock's canal. So that is the muscle of your piriformis maximus. This is the anatomic. There is anesthesia. So you have these variations. It's very rare. Some of this is like possible 10-15%. This has been taken out again. So this is that. I couldn't get time. So starting with the PS, my first you can see you can of your glottocytic nerves, you break in the bone as you approach the glottocytic nerves. So from there you need to tilt your probe little lateral, orient in an oblique manner to look into the piriformis. So that is how it looks like gluteus maximus and the piriformis. And then you have to do a bit of maneuver. You need to bend the knee and do a internal to appreciate the piriformis muscle. So here these are the various things. This is your gluteus maximus, piriformis, this is the part distal part acetabulum, and this is your sciatic nerve, and that is your piriformis muscle, bulk of that. So if you see here, it is in vicinity of your sciatic nerve, the piriformis. If you go a little deeper, inject a lot of piriformis. If you go a little deeper, inject a lot of volume. You are not careful, you can post procedure will see that patient is limping. There is a foot drop. Okay. So now the next part is that did I skip a video? No. Okay. The next part is that from that scanning, slowly come down, you reach that ischial spine. Once you reach that ischial spine, the medial side to the ischial spine will be your sacrospinous ligament. Okay, that sacrospinous ligament, this is medial, that continues as a hypoechoic line. Okay, so this Malantic of your gluteus maximus, the inferior part of the deeper part of the gluteus maximus is the sacrotuberous ligament. This is your sciatic nerve on the top of your gemellus superior there. So this is the artery that you see there, and the nerve should be over there, medial to the artery. So don't be confused about another pulsation which accompanies your sciatic nerve. This is your inferior gluteal artery. So there are basically 2 pulsations. The pulsation which is little lateral is your inferior gluteal artery. The pulsation which is the medial, that is your pudendal artery, and the nerve is medial to it. So that is different, because if you inject that inferior will end up with a sciatic nerve block, not a pudendal nerve block. So again, to start with, I start this scanning technique. I do have a YouTube video also. You can check that gluteal and pelvic scan. I'm sorry that I could not. I was given the task in the very last moment. I could not rearrange the slide here. So I start with the PSIS. Okay, I slowly go down. So that is what you see: gluteus maximus, medius, and minimus. And as I approach this area. Okay, so that is the piriformis muscle there, bulkier. This is the sciatic nerve, ischium, gluteus maximus. And when you do the injection, I told you for a hip injection also, you don't go next to the ultrasound probe, unlike a linear probe. You have to go 2 centimeters away from the probe. If you do that with the heel to maneuver that you employ, even for a deep block, you can almost visualize your needle tip, because that will get reflected. The angle of that inclination, if you remember the very basic physics of the target wall of the muscle here, or maybe you can go that way, but don't go too deep. Keep this in mind. Okay? And when you come also on the top, you can see those piriformis vessel, this superior gluteal artery also. So that you need to avoid, because if you pump that, you can have a hematoma also. So the artery that you see here, that is inferior gluteal artery, this thing I discovered. Is pain in that moment you sit and the moment you sit, the pain may not get reduced significantly. Some of the pain may continue when it becomes chronic. Okay, so not but night. That should not be an objective sensory loss and a positive response to a diagnostic blow. So that's the criteria for a pudendal nerve block. So again, pudendal nerve, as I told you, it comes out from the glottocytic foramen from base 2, 3, 4. As it leaves the glottocytic foramen, from that area it travels between this this is your sacrospinous and the sacrotuberous ligament. In that interligamentous plane it travel and then wraps around the your obstetric internals and goes into the alpha canal of the lesser sciatic foramen, divides into three branches. Dorsal nerve of penis circulatoris, you have a rectal, inferior anal nerve, inferior nerve, and also the perineal branches. So these are the three branches it gives out. So pain is around that area. So the potential nerve is related to basically from the ischial spine there. Okay, that is ischial spine, that is sacrospinous ligament. So this is sacrotuberous and the sacrospinous ligament. So this is just to show you between the two ligaments, sacrospinous and the sacrotuberous, that it goes. Okay, so this is your sacrospinous ligament. So now the technique is again, but anytime I start with the exercise, because I go in a systematic way so that you don't miss anything, because this is a deep block, you may miss it, you will find it difficult to do also. If you scan in a systematic manner, you can do it very well most of this. So once I do that, my step one is going to the next part, the base, the metastatic nerves, I see for the piriformis as this is your nerve, like this is little oblique oriented, and in that oblique I'll scan down until I reach the ischial spine. See here, that is the bony contour, it is little curved here, that is ischial part of that muscle, that bone there. So little curve, as you reach the getastatic nerves, that ischial spine, this will become straightened, okay, and medially your sacrospinous ligament will continue like this. Sacrospinous, another hyperechoic ligament that will continue medially. If you scan into cephaloid and caudal, you won't see that hyperechoic ligament. And if you put collodoppler, be sure that you see that medial most collodoppler as the internal pudendal artery, not the lateral one, which can be inferior gluteal artery or next to the sciatic nerve. And this is again just to show you, I'm reaching that area. See here, this will become straightened. Now I'm going to reach the ischial spine, and medially that continues. Did you see that? If I scan little down and maybe up, so that when you reach the ischial spine, that bone will become straight. When it was at the piriformis, it was a little curve. So once you reach that area, medially that sacrospinous ligament will continue as a continuous hyperechoic line. I'll just play this video once for all of you to have a look at this part. Okay, so I'm starting from the piriformis. This is your sciatic nerve. As I'm slowly reaching, this is becoming straight, and medially, look at that is that hyperechoic line. That is your sacrospinous ligament, and this is sacrotuberous ligament. Once you reach this area, so look for the pulsation, the medial most, the internal pudendal artery. Your needle has to come in plane from medial to lateral like this, 2 centimeters away from the floor. It's a flat angle, and then reach there. So this is from my fellowship days, 2015 I guess. So this is sacro, and this is just a 22 gauge spinal end. Okay, so just to refresh the anatomy, scan at top area PSIS like this, Gmax, medius, minimus. When you reach the B, that is your getastatic nerves, like a curved area like this, curve, piriformis and Gmax. And when you reach the C, ischial spine, like a straight line, and the sacrospinous ligament will continue medial. So keep these pictures in mind if you do that. When you go further down, for a lesser sciatic nerves, you'll see like a curve. On top of that, your obstetric internus will wrap around. Okay, and you can do further medially. Hope you kind of got into it. It's a difficult one. Thank you very much for your kind attention.
Thank you, Dr. Saul, for nice pictures and this thing. I'll request all the speakers to come to the dais for the group photo, and any questions from the audience.